Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Alan Lindemann. He is an obstetrics gynecology physician. His Kevin MD article is titled Breaking the Silence, A Doctor's Plea for Clarity in End-of-Life Care. Alan, welcome to the show.
Yes, thank you, Kevin, very much.
So we'll get into your article in a little bit, but first off, just briefly share your story and journey to where you are today.
Well, tomorrow I'll be 75 years old. I grew up in a small farm in North Dakota. Our nearest town was 20 people, so most people can't even imagine that. My dad died when he was 39. He always said life begins at 40. I was 1 month into 11, so I very soon developed an interest in life and death matters. And I was always a serious young guy to begin with, so I was the oldest of three. And so I assumed a position of responsibility. And I also recognized vulnerability, and that's what drove me to my career.
So tell us, what's it like to practice in a rural setting?
Well, one of the problems that we have in rural America is that we have to be a jack of all trades. So people keep asking me, why is an obstetrician talking about nursing homes and death? Well, that's because we practice here the way it was probably done 40 to 50 years ago, where you did what you had to do. And one of the biggest problems we have is getting our patients sent out, especially during COVID.
Give us a story or a case study or an example of that.
Well, years ago, we could send out patients easily, but now with COVID, you could spend hours on the phone trying to get a patient referred, and you may not even be able to do that. So sometimes people even die in the process of trying to get them out of here. And we have to be good at many different things, all the way from intubation of little people, intubation of big people, and then, of course, for the most part, COVID wasn't a real big problem here. We managed most of our COVID patients in the clinic, but we had a lot of COVID patients for a while, no longer that many. So yes, it's lonely.
Now, from an obstetrics gynecology standpoint, just give us an idea of how the rural setting affects your specialty in particular.
Well, of course, there's getting to be more and more obstetric deserts. And again, the problem is referral. For example, when I practiced in Fargo, which of course is much bigger than where we are now, I had my own ultrasound machine in the office. But of course, here we have ultrasound coming on Mondays. So it's a very different way. We are deprived of a lot of the equipment and the assistance that we need to practice. But the thing about obstetrics is you have to love it, and you can't be afraid of it.
All right. So let's talk about your Kevin MD article. It's titled Breaking the Silence, A Doctor's Plea for Clarity in End-of-Life Care. Now, how did this article come together?
Well, we talked a little bit before about vulnerability. So I've always been aware of how vulnerable young people are, babies. But also, I've spent a lot of time now managing nursing homes. And the young and the old have that in common. They're vulnerable. So when this 93-year-old man told me he wanted to be treated like a 73-year-old man, I could understand that. And I also understood that because he could ask that question that way, that he had some ability to think and consent and also refuse treatment. So he was mentally with it.
Now, what did he mean by that when he told you, as a 93-year-old man, he wanted to be treated like a 73-year-old? What did he mean by that?
Well, sometimes what happens with our people when they get older is we confuse the terms of do not resuscitate and do not treat. And he was definitely he understood that there was a difference, that he wanted the same treatment we would give to a 73-year-old, and he wouldn't want us depriving him of treatment because he was 93.
Now, what would be some examples of those treatments?
Well, for example, simple things, even like a bladder infection. When one of the problems we have in the nursing home, for that matter, even when people get to be over 70, they get a bladder infection and they get confused. And then the people around him say, oh, well, he can't make any decisions. He's confused. So let's just let him die. So we can have people dying from bladder infections and, of course, pneumonia too. So, yeah, he knew what he was talking about.
Now, from this patient's experience, had he had specific treatments refused to him because of his age?
I think that as long as I was there helping him, he got the treatments he needed, but he was worried about it. And yes, I think that probably because of who he was, maybe they tested his urine a little bit later than they might have with somebody else. I'm sure he had, I mean, I don't know exactly where he was coming from, but I do understand that he knew what he was talking about.
Now, from your experience in the nursing home, how common is that scenario where people who are able to make their own medical decisions but are perhaps in their late 80s or 90s aren't being treated? Is this fairly common from your experience?
I would say it's quite common. And, you know, one of the problems we have in nursing homes is that we get used to people dying
Hmm.
and you get kind of immune to it. And as far as I'm concerned, when we get to the point that we take somebody's death, if we don't take it seriously, if we aren't bothered by it, we should go on to doing something else.
So you mentioned earlier the difference between do not resuscitate and do not treat. And sometimes the line becomes blurred. So tell us, what are the differences between the two in your mind?
Well, for example, we've been talking about pneumonia, you know, and also I'll give you the example of somebody who came in and I didn't take care of this patient, but she was a do not resuscitate, but she was having an asthma attack and she was in her 80s. And her family came with, oh, do not resuscitate. So that meant we couldn't intubate her, or they couldn't intubate her, and she couldn't be sent anywhere. So there was confusion there. And I think there's a lot of confusion. It's a slippery slope. It's easy to go down the wrong way here.
Now, what can clinicians do to prevent scenarios like this from happening?
Well, I think first of all, everybody needs to know that there is a difference. We should not never, for example, decide to not treat somebody for a bladder infection. Although, you know, the news that we're getting from Washington, D.C. is we're not supposed to diagnose bladder infections. On the other hand, we're also not supposed to have urosepsis. So we have that political process playing in this. But yes, everybody, I think that every time somebody gets confused, we should be thinking in terms of sepsis. We should be thinking in terms of the most common thing, like I said, would be a bladder infection, kidney infection, urosepsis. So yeah, we need to think about that. And we need to make sure that we don't get those things confused. I think that doctors, nurses need to understand that. And also the patients need to understand that, and the relatives.
So let's ask that question another way. What can patients do to make sure that they're not subjected to do not treat when they should, in fact, be treated?
Well, that's more complicated. In the first place, the patient has control as long as they're not in the nursing home. In other words, if I have an 85-year-old presenting to the emergency room, that person is probably going to get a different kind of care than in the nursing home because they're not going to be automatically dismissed based on their age. The patient needs to come in and the patient needs to explain what's happening. Yes.
Now, cases like these, like the one that you told in the Kevin MD article, how has that changed how you treat patients?
Well, one of the things I have to do is try to ignore some of this stuff that comes out of Washington, D.C. In other words, you know, when I was being trained 45 years ago, we were supposed to identify bladder infections. We were supposed to treat them vigorously for 10 days. Today, of course, we're supposed to ignore them. We're supposed to treat them for 3 days. So things are very different. But I'm an old doctor and I still remember the way things used to be. And one of the things about medicine is that you can do a 180-degree turn in not a lot of time. And usually the truth is in the middle, you know, not at either. Stay out of the extremes. So listen to these people who come in with their complaints, their bladder, whether it's a urinary tract infection, whether it's burning, dysuria, whether it's change of mental status, they should be treated or identified.
Now, what about your other clinician colleagues? Do you see them kind of falling into that trap, so to speak, or are they pretty cognizant and aligned with what you're seeing?
I think that there's an awful lot of doctors who do just exactly as they're told to do. And I know that, I mean, that's one of the things about being my age is I don't always have to do exactly as I'm told to do. And so I can make up my mind based on the individual patient who comes to see me. But yes, there's an awful lot of doctors who do exactly what they're told to do. And sometimes it's not very good advice. For example, PSA testing. We were told not to do that. And oh my goodness, look what happened. We've got no prostate cancer. Well, of course, 5 years later, there's a lot of prostate cancer and it's not treatable. So yeah, we get a lot of bad advice that we don't have to follow.
Now, give us an example of some of the pushback you may receive, because sometimes you're right. Medicine is becoming more what we call, cookbook driven, algorithm driven, guideline driven. Now, sometimes pushing back against that can be difficult, especially not in rural settings, but in larger organizations. So how can doctors push back against some of these guidelines that they individually may not agree with?
Well, it's very difficult to push back. For example, we have something called antibiotic stewardship now, where, if you treat people with an antibiotic, like for bladder infection, that's considered the wrong thing to do. But we can all make up our minds. Naturally, we'll probably have to face some fallout. I mean, we may be listed as not being good stewards of antibiotic use, but I think we have to be willing to take the heat for that.
We're talking to Alan Lindemann. He's an obstetrics gynecology physician. His Kevin MD article is titled Breaking the Silence, A Doctor's Plea for Clarity in End-of-Life Care. So, Alan, obviously you've had decades-long experience in medicine, especially in a rural setting. Now, for those new doctors, residents, interns, medical students who may be listening to this, what's one piece of advice you could pass on to them?
Well, I'd like to say, make up your mind, have your own opinion, and be able to take the heat for maybe not conforming to every single thing that comes along. We still have to think.
And my final question, just tell us some take-home messages as it relates to your article to the Kevin MD audience.
Well, all of us will eventually be faced with our own mortality. We will all eventually get to the point of maybe signing one of these POAs or whatever it is. But for the sake of our patients, we need to really define that, and we need to define it for the patients, and we need to define it for the relatives of the patient. But there's another message here, and that is for yourself. I, for example, know very clearly the difference, and I will go down fighting for the difference when it comes to my own life. And I think I may sound selfish, but I want to die at home.
Alan, thank you so much for sharing your story, time, and insight. And thanks again for being on the show.
Thank you very much, Kevin. Thank you.